All right, let's talk about one of the biggest headaches in head and neck imaging, the suprahyoid neck mass. It can seem totally overwhelming, but believe it or not, there's a beautifully simple, systematic approach that can cut right through all that complexity. So let's dive in.
So you get a scan, right? And boom, there it is, a mass sitting deep in the neck, and your list of possible diagnoses is just a mile long. So what is it? Benign? Malignant? Coming from a gland? A nerve? A vessel? I mean, where do you even start? It's a classic challenge for sure, but the key to unlocking the whole thing is often hiding in plain sight.
That's right. Believe it or not, the secret isn't even in the mass itself. It's all about how that mass pushes on one specific structure, the parapharyngeal fat. By just analyzing the direction of that push, we can systematically figure out where the mass is coming from and build a really powerful targeted differential diagnosis. So here's our game plan. We'll start with our diagnostic GPS, which is that parapharyngeal fat. Then we're going to march right through the 4 major spaces covering their key pathologies. We'll also touch on the really critical topic of deep neck infections, and then finally, we'll put it all together into one master map.
All right, first things first, we need to lock in our landmark. The entire system we're about to learn really hinges on understanding this one central fat-filled space. Okay, so this parapharyngeal space, or PPS for short, is basically just this cone-shaped chunk of fat. Now, it has a few small nerves and veins in it, but its real superpower is its location. It's bordered by 4 other critical spaces, so when a mass pops up in one of them, the very first thing it does is push this fat out of the way.
And this right here is the key to everything. These are the 4 vectors of displacement. A parotidial mass pushes the fat medially. A carotid space mass shoves it forward or anteriorly. Masticator space masses push it posterior-medially, and superficial mucosal space masses push it out laterally. Seriously, memorize this. This is your cheat sheet for every single suprahyoid neck mass you'll see.
Okay, let's put this into practice with our first vector. If you see that parapharyngeal fat getting pushed medially, you know without a doubt you're in the parotid space. Just remember the mnemonic, PMPM. Parotid mass pushes medially. So the most common player on the field here is the pleomorphic adenoma. It's typically super bright on T2 images with a nice dark rim. And the second most common is the Warthin tumor. This one has some classic associations. The classic story is an older male smoker, it's often cystic, and you gotta remember, it can even show up on both sides.
And here is a fantastic high-yield pearl, especially for your exams. If you happen to have a nuclear medicine scan, the Warthin tumor just soaks up pertechnetate. This is a nearly unique feature that can absolutely nail the diagnosis. It's a great little fact to keep in your back pocket.
Now, before we jump into the scary stuff, let's talk about a super important rule of thumb. The smaller the gland, the more likely a tumor inside it is malignant. The flip side is true too. The bigger the gland, the more likely it's benign. So the huge parotid gland, mostly benign tumors. But those hundreds of tiny, minor salivary glands, they have a much higher chance of malignancy. Bottom line, size matters. All right, on to the malignancies. Mucoepidermoid is the most common one overall, and it especially loves those minor glands. For adenoid cystic carcinoma, the buzzword you absolutely have to know is perineural spread. And if you see bilateral masses in a patient with Sjogren's syndrome, your alarm bells should be screaming lymphoma. The risk is just astronomical, and you might even see this classic honeycomb pattern in the gland.
Okay, let's move on. Vector number 2. If you see that parapharyngeal fat pushed anteriorly or forward, you're looking at a carotid space mass. And this space is home to our major vessels and a bunch of cranial nerves, 9 through 12.
The differential here is pretty classic. It's really dominated by these big 3 tumors. You've got Paragangliomas, which are super vascular and give you that classic salt and pepper look on MRI from all those little flavoids. Then you have schwannomas, which are often more heterogeneous. And finally, neurofibromas, which can have that beautiful target sign on T2 and are really strongly associated with NF1.
Now, when you're dealing with paragangliomas, which are also called glomus tumors, location is key. But here's the absolute critical distinction, the thing that separates these two. A glomus jugulare is an aggressive tumor at the skull base that erodes and destroys the floor of the middle ear. A glomus tympanicum, on the other hand, stays confined to the middle ear, leaving that bony floor completely intact. That is a make-or-break finding.
Okay, now here's a really common pitfall. You'll see a schwannoma and it's enhancing like crazy, just brilliantly bright. And you're going to think, wow, that's got to be hypervascular, right? Just like a paraganglioma. But it's a total illusion. If you did an angiogram, you'd see it's actually hypovascular. That intense enhancement isn't from a rich blood supply. It's just from leaky vessels that let the contrast seep out into the tissue.
All right, let's knock out the last two displacement patterns real quick. A posterior medial push points you to the masticator space. That's home to all our chewing muscles. And a lateral push points to the superficial mucosal space, which lines our pharynx.
So, you see a masticator space mass in an adult? Most of the time, it's going to be an odontogenic infection. So, what do? You always check the teeth and the mandible first. Now, in a kid, you have to worry more about aggressive sarcomas. And for the mucosal space, the pathology is almost always squamous cell cancer that's spreading from the pharynx or larynx.
Okay, let's shift gears a bit, because beyond tumors, these spaces can act like highways for infection. And this is where things can get really serious really fast.
So check out this pathway. This is how things can go bad. An infection, say from the tonsils, can spread back into the true retropharyngeal space. If it's bad enough, it can bust through a thin layer called the alar fascia and get into something called the danger space. And yeah, it's called that for a very good reason. It creates a direct, unimpeded highway from the neck straight down into the chest.
Now, when you're reporting on these infections, the number one question the surgeon is going to ask you is this. Is this a phlegmon, which is basically just angry inflamed tissue, or is it a true drainable abscess? An abscess will show up as a nice, well-defined, rim-enhancing fluid collection, and sometimes using delayed imaging can be absolutely critical to make that distinction and guide the surgeon.
And finally, there are two classic named syndromes you should definitely have on your radar. Lemierre's syndrome is a septic blood clot in the jugular vein, often caused by a nasty bacteria called Fusobacterium necrophorum after a simple sore throat. Then you have Grisell's syndrome, which is an inflammatory torticollis or a really stiff neck that can happen after head and neck surgery or a bad retropharyngeal abscess.
All right, we've covered a ton of ground. Let's bring it all home and put our complete diagnostic map together on one slide.
And here it is. This is the whole system, the whole shebang in a nutshell. By simply identifying which way the parapharyngeal fat is being pushed, you can pinpoint the space of origin and immediately whip up a high-yield differential. Medial push, think parotid tumors. Anterior push, think the carotid space big 3. Posterior medial, go check the teeth. And lateral, look for a mucosal primary cancer. It's that simple. It's that powerful.
So what's the big takeaway here? It means you now have a rock-solid framework. Instead of getting overwhelmed by a neck mass, you can walk up to it with confidence. The next time you see one of these deep neck masses, you know exactly what to do. The very first question you ask yourself is, which way is the fat being pushed?